So for decades, we actually did not have any significant changes, both in the diagnostic and the pharmacotherapeutics for Alzheimer's disease. But in the last few years, and actually in the last couple of years, there has been a rapid advancement in the field of dementia with a number of new therapeutics as well as diagnostic tests. And so now more than ever, there's a heightened need for an early diagnosis. So today we are going to address the advances in the diagnosis. What I had said was that for decades, we have not had any significant changes in both in diagnostics and therapeutics. And in the last few years, there have been a significant advancement in the field of dementia. In fact, it's actually in the last couple of years. So now more than ever, we want to kind of focus on an early diagnosis. So today we are going to talk about the advances in diagnostics, therapeutics, and some newer care models. Now, Alzheimer's is one of the types of dementia under that big umbrella term of dementia. But we talk about Alzheimer's mainly because it accounts for nearly 70% of all dementia cases. And then even many times, especially after age 85, many times the dementias are actually mixed with a component of Alzheimer's. So according to the 2024 Alzheimer's Association stats, there are nearly 7 million Americans that are now living with Alzheimer's. And by 2050, it is estimated that this is going to increase to nearly 13 million. Now, this does not only affect the individual, it involves the care partner as well. So there's significant both medical as well as financial burden. Before we go further into the newer tests, I thought we'd go back a little bit and understand the pathophysiology. Now, there are multiple theories that have been put forth, but the amyloid cascade theory is the one that is most agreed upon. So the hallmark neuropathological changes that occur in Alzheimer's is the formation of the amyloid plaques and the neurofibrillary tangles. Dr. Alois Alzheimer in 1906 first identified actually these proteins when he did a histopathological diagnosis of his deceased patient, August Dieter. And so these proteins are believed to lead to all the neurodegenerative changes and ultimately Alzheimer's disease. So this is the amyloid cascade theory. So what did they believe? Either because of genetic mutations, environmental factors, or maybe with aging, there is an abnormal protein processing and polymerization. I'm not sure if you all will be able to see my mouse arrow, but what happens is this amyloid precursor protein, it gets cleaved and it results in abnormal proteins which are more sticky. So normally we would have soluble amyloid, beta amyloid proteins, which would then be able to be removed. But here what happens, it gets, forms these dimers, oligomers, then protofibrils, fibrils, and the amyloid plaques. It is believed that oligomers, protofibrils, and the fibrils, they are like neurotoxic. And so that causes these changes in the brain. What happens is when they form these amyloid plaques, it then interrupts the synaptic transmission, which leads to cell death. The other thing, what they feel is, and there are two theories on this. So in the amyloid cascade theory, what they feel is that this also sets up a process which causes hyperphosphorylation of this tau protein, which then causes it to not be very stable and forms these tangles. And this is in the microtubules, which are important for transmission, nerve transmission. So that combination causes cell death. There's another theory which is the tau hypothesis, which they believe the process that happens or the hyperphosphorylation of the tau is occurring independently of the amyloid. And there are multiple reasons why some people do not believe that it is the amyloid that is the main factor that causes the cell death. It's because one, it is present as we get older. Two, they have had instances when they've done autopsies and they have found a lot of amyloid in the brain, but the individuals did not have memory issues or Alzheimer's. So there is still debate on what is the actual causation. So there's still multiple theories, but this is important because now we have newer diagnostics as well as newer therapeutics, which are based on these proteins. And they act like we have two new medicines, and we'll talk more about them later, which is called lecanemab and donanemab. Lecanemab acts at the protofibril, while donanemab acts at the amyloid plaque. So they act at different points, and there are newer medications in research going on acting at different proteins, but also in different parts of this whole amyloid cascade, kind of the inflammatory level, the tau level. So kind of acting on this whole process in multiple ways. That's why I think this is very important for all these newer medicines. The biomarkers. So as you can see, this on the x-axis, we have the cognition. And on the y-axis, we have the different biomarkers, the rate of growth. And as you can see, that this red is amyloid. This amyloid is positive for years before you have any symptoms. So it's believed that it can be positive even 20 to 25 years before people actually develop symptoms. This blue is the tau, and the tau protein kind of correlates more with symptoms. As you can see here, it kind of tends to get steeper when we are moving from MCI to dementia. The green is the neurodegeneration, and so changes in the brain. And the purple, light purple, would be memory, and this darker gray would be function. So as you can see, there's a big interval of time before we even get MCI, so even mild symptoms. And I should say MCI, and we'll talk about it more, is what we call as mild cognitive impairment. So there is memory, you can have memory issues, but you're still independently functioning. This interval is important also because that's where a lot of research is going on to try and search for medications that can act on the process even before symptoms occur. And so that would be the way then to actually completely prevent it and potentially cure it. The other thing is, this is also the phase where we talk about a lot of lifestyle measures, if I introduced it this time. So this would actually be more in middle-aged individuals. So if you keep all your vascular risk factors, do all kinds of things to help cognitive reserve, this can then help delay the onset of symptoms. So moving on, so biomarkers can be divided into, we can divide them into like the neuroimaging, the CSF biomarkers, and now we have even plasma biomarkers. Now, for years, actually not years, decades, biomarkers were only in research. But now we have, more recently, biomarkers even at CSF level. And actually just recently, in May of this year, the plasma biomarkers were approved, FDA approved. So I have to say, means this field is changing so fast in this last few years. Like every month or so, we have something completely different, new that is showing up. So as far as the biomarkers, the neuroimaging, it can be the MRI without contrast. And this is good, one, to kind of exclude the presence of any masses. It also gives us an idea of the vascular burden, so if there's any vascular disease. And then also you can look for atrophy. So especially in Alzheimer's disease, there is atrophy at the hippocampus and the medial temporal lobe. The other thing on the neuroimaging would be the PET scan or the amyloid PET, where you use the amyloid tracer to identify amyloid in the brain. CSF markers, we have the amyloid beta amyloid 42/40, and you can do that ratio, as well as the tau proteins. And you can do the total tau as well as the hyperphosphorylated tau. And now, similarly, we have this, the beta 42/40 amyloid protein in the plasma that we can detect, as well as the phosphorylated tau. There is the p-tau 217, which is highly sensitive for Alzheimer's disease. And actually, since the onset of the biomarkers, in June of 2024, the Alzheimer's Association revised the criteria for Alzheimer's disease, wanting to make it more a biological diagnosis. There's still a lot of controversy on this, but that's kind of in the direction we are heading. And I do have to mention that even though we have these biomarkers, we are not using these as screening measures. These are used essentially in individuals who are symptomatic, and we have to do like the initial workup, which would involve a detailed history, assessing all their chronic medical conditions, reviewing their medications, seeing if they have a family history, any substance use, especially alcohol, any behavior or personality, doing a thorough physical exam, including a neurological exam, a cognitive assessment. We generally use the MoCA, or the Montreal Cognitive Assessment. You can do like a neuropsychological testing, do depression, anxiety screen, functional assessment, and then check labs for reversible causes like B12 deficiency, thyroid, any electrolyte issues. And also sleep, especially sleep apnea, is a common thing that can cause memory issues. And we do all of this before we actually get into the biomarker testing. This is a slide just to kind of explain the continuum of Alzheimer's disease. As I mentioned earlier, that for years we can have positive biomarkers and positive amyloid, but still not have symptoms. So that's like our preclinical phase. Then we have MCI, and MCI is a stage where you have subjective memory, cognitive symptoms, but you also are positive on an objective test like a MoCA, but function is not affected. And then the next phase would be dementia. Now, dementia can be divided into mild, moderate, and severe, depending on the extent of activities and the severity of the disease. So in mild, it's usually, most people can actually be pretty independent. It's some activities, more of advanced activities that get affected. Moderate, you're needing some assistance with even basic activities, and severe, you're essentially dependent for care. So for years, so now we'll talk a little bit about the medications. And as I mentioned, for years, we had mainly two classes of medications. The anticholinesterase, which was the donepezil, rivastigmine, or galantamine. And these medicines actually were helped with symptoms. So they increased the acetylcholine level, and that was helped to reduce some of the symptoms of the Alzheimer's disease. The other medication in this group is the NMDA antagonist. And the only one in this class was the memantine. Now, some common side effects of these medicines, like with the anticholinesterase, there is, it's mainly GI, so you can have decreased appetite, weight loss, sometimes loose stools. In some people, you get like strange or vivid dreams, and some people also have bradycardia. So, especially in individuals who have syncopal episodes and they are on these medications, you need to reconsider the use of these medicines. For memantine, it's usually like constipation, then you can have headache or dizziness as potential side effects. But the new and the thing that has happened in the last 2 years is we now have two disease modifying drugs, and that is lecanemab and donanemab. The first medicine in this group was actually aducanumab, which had an emergency authorization in 2020, but then it was removed from the market in 24. So lecanemab was approved in July of 23 and donanemab in July of 24. Both of these medicines are approved only for Alzheimer's disease, and you have to be early in the disease. So it's either MCI or mild cognitive impairment or mild dementia. And to be able to get the medication, you have to have biomarker proven disease. And currently, the biomarker proven can only be either by a PET scan or CSF. The plasma biomarkers are not yet accepted. So the phase 3 study for lecanemab was the Clarity AD. And this was a double-blind randomized study where the patient population was about 1,700. They were equally divided either into drug, lecanemab, or placebo. And the primary outcome measure was the CDR, which is the Clinical Dementia Rating Sum of Boxes. And so that was an idea of the cognitive and functional effect of the patient. So, yeah. So here, the green line is the drug, the lecanemab, and the black line is the placebo. And as you can see, there is like a 27% slowing of decline. So there was an improvement in both of their primary endpoint of cognitive and functional, the CDR-SB. And their secondary endpoints were mainly as far as the individual's ability to function as well as amyloid clearance. And it did have significant amyloid clearance at about 12 months. The important thing is adverse events, because these medications do have some serious side effects or adverse events. The infusion reaction was the most common. That was in 26% in the drug group and about 7% in placebo. And the other important side effect is what we call as ARIA, or amyloid-related imaging abnormalities. And there are two types, and we're going to talk more of it under adverse effects later on. But there are two types. The E is the edema, and the H is the hemorrhage. And as you can see, it was 21 in the drug group and 9 in the placebo. But most of the cases are actually not symptomatic. It is there was about 3% individuals who were symptomatic. So subsequently, they have had an open label extension of the study. And the green is the individuals who were on the drug and then were continued. The black and then green were individuals who were on placebo, which were then continued on the drug. And the bright pink is what we would, it's based on a large observational study, but that is really what, assuming what the natural history of the disease would be. And as you can see, there was a sustenance of the slowing of the decline. And so they felt like nearly 59% of people showed no decline. And some even showed improvement from their baseline. So that's on the lecanemab. It is given as an IV infusion. It has to be given every 2 weeks. So it's twice a month. Every 2 weeks, it has to be infused. The second medicine in this group is donanemab. And the phase 3 study here was called the Trailblazer-ALZ 2. And in this medication as well, there was about 1,700 people. It was a randomized double-blind study. Here, the primary outcome was what we call as an integrative Alzheimer's disease rating scale. It is a scale that's used in research, but again, it mainly assesses cognition and function. The other key thing in this donanemab group, what they also kind of analyzed was they subdivided the results into the low tau group. Now, the low tau group would be kind of an equivalent to individuals who were earlier diagnosed. And so in the low tau group, they had like 37%. And in the combined group, it was 22%. Slowing of decline. So it is not improvement that happens with these drugs. These drugs help to slow the rate of decline. The other key thing that happened with this medication is what they did in the study, that they also did periodic amyloid PETs. And when they saw that there was clearance of the amyloid, they switched the individuals to placebo. And the patients were still blinded, but they were switched to placebo. And so they found that the cognitive benefits also persisted till the end of their study at 76 weeks. So in the labeling also of this medication, it does say that you can stop the medication after there has been amyloid clearance. In the adverse events here too, the infusion reactions were about 9. Here, the symptomatic ARIA are higher. It was at 6%. Then a little bit about the inclusion and the exclusion criteria. So on this side, this is what the inclusion criteria for the study, the Clarity AD. And I have it as the Clarity AD, but the inclusion and exclusion criteria were pretty similar for both of these studies. So both the Trailblazer and the Clarity. And on this side is what we would have the appropriate use recommendations. And so, as we said before, it is for early disease. So MCI or mild dementia, you have to have mild Alzheimer's disease dementia. It has to have positive biomarkers, so either an amyloid PET or CSF. Plasma biomarkers are not yet accepted. And then you have to, you can be on the donepezil, the cognitive enhancing medicines, but the other medical illnesses should be stable. And the other important thing is you have to be able to have an MRI and you have to have a care partner, because you do need somebody else to be able to assist you in this process. There are also significant exclusion criteria. And so one of which would be that the dementia is related to Alzheimer's disease, because you do not want to take these medicines with their associated risks and have another dementing process happening. And as we said earlier, sometimes we have mixed dementias. So it has to be an Alzheimer's disease related. no recent history of a stroke or seizures. Mental illness should be stabilized. No immunological diseases or be on monoclonal antibodies. Anticoagulants, that increases the risk for bleeding and any bleeding disorder. And then, as part of the workup, you would do a baseline MRI, and individuals who have more than four microhemorrhages, and a microhemorrhage is where it's less than 10 millimeters. So more than four microhemorrhages, a single macrohemorrhage, if there are multiple lacunae infarcts or severe vascular disease, or superficial cirrhosis or edema on your baseline scan. So these would be some reasons to exclude the individuals. So talking a little bit about as far as the adverse effects. So as we mentioned, infusion reactions, this occurs most frequently, about 9 to 26% of all cases. It generally tends to occur more earlier in the disease process. The symptoms can vary. It can be mild in the form of chills, fever, or like nausea, or it could be chest pain, shortness of breath, dizziness. So there's a whole wide array of symptoms. And the most of the time it's mild to moderate, and many a time you can just stop the infusion or slow the infusion or pause the infusion. Sometimes you need to use antihistamines or steroids. The other big one is the amyloid-related imaging abnormalities, or the ARIA. And this is actually on a box warning as well for these medicines. It occurs about 12 to 36% of all subjects. Most of the time, as we mentioned earlier, it is asymptomatic, but it can cause like headache, confusion, gait disturbances, and it can also cause like bleeds. So you can have seizures as well. It usually occurs more frequently in the first 6 months of the infusion therapy. It is believed in the process of taking out the amyloid, there's leakage of both fluid or blood, and that leads to this, can cause the microhemorrhages. And so, as a result of because of this potential side effect, there is dedicated MRIs that have to be done to help prevent this complication. So as we mentioned before, we'll have a baseline MRI, and that is to kind of rule out anything that exclude this individual or also other causes for memory loss. Then you will have before the 5th, 7th, and 14th infusion for lecanemab. And then in some people, the 52nd infusion, anytime there are symptoms. So you have to have a low threshold for getting an MRI in individuals on these medications if they have symptoms. With donanemab, we have the baseline, then before the 2nd, 3rd, and 4th infusion, and the 7th infusion. And then again in a year if needed. It's in some patients, it's not necessarily in everybody. And again, you would do an MRI if the individual had symptoms. So who are the individuals who are higher risk for ARIA? So it tends to be more if you have more vascular amyloid. So if there's vascular amyloid, cerebral amyloid, angiopathy, individuals who have more microhemorrhages on the initial scans, on anticoagulants, and people who are, especially if they are homozygous for the ApoE4 allele. So the risk if you are homozygous for the E4 allele actually nearly doubles. So some of the ways to help reduce this risk is the scheduled MRIs, as we discussed, and these individuals have to be in a Medicare registry. Most of these cases is usually it is not symptomatic, but in some individuals it is. Most of the time, there is a whole protocol that one has to follow if ARIA is detected. Most of the time, many a time actually, you can kind of stop the infusions and wait till it resolves and then maybe be able to restart, but in some individuals you can't. In some cases, you need to actually treat with steroids, and in some individuals who have seizures, you would treat with seizure medications. So before we go to the next aspect with the care models, we're just really, as far as these medicines, these are new and it's a big change to the field in, especially in Alzheimer's disease. But these medications, it's not for everyone. There are certain risks, and so it depends on the individual. The cost, the time factors. So there are multiple things that go into whether this is appropriate for an individual. Next, we'll talk about this new care model that this is actually called GUIDE, which is Guiding an Improved Dementia Experience. This is CMS or the Medicare Innovative Project. It's an 8-year pilot program, and it's to help patients and their caregivers better navigate healthcare and the social support systems to improve the dementia care. It has 3 primary aims. The SKY program has 3 primary aims: to improve the quality of life for the people living with dementia, reduce the strain on the unpaid caregivers, and enable the people living with dementia to remain in their home and community. So it was started in actually last year. There were two kind of paths you could take. There was the established, and we are in the established part, which started last year in July, and the new programs which started this July. So to be able to enroll in GUIDE, you have to have a dementia diagnosis. It has to be dementia, so mild cognitive does not count here. And you have to be enrolled in traditional Medicare. You cannot be enrolled in hospice, and you cannot be in a long-term care. You can be in an assisted living, but not long-term care. And the services provided through the SKY program, it gives you access to the care navigators, and these care navigators do caregiver training, monthly or intermittent check-ins, support, connect you to different resources, help with healthcare navigation, actually coordination. And the other key thing, it actually provides respite care dollars. And that can be put both for in-home care, it can be for an adult day center, or even in a long-term care. And of course, we have medical oversight, so 24/7 accessibility. So this is big in a lot of terms as far as dementia care, because it is also highlighting the care partner and the caregiver, because for years it's always been fee for service and it's only the patient, but this is giving focus and understanding that in dementia care especially, the caregiver plays a big role as well. So to summarize, as you can see, there are a lot of advancements, and I'll tell you, probably in 6 months, this may all be a lot of old news because it's changing so fast. And we have now newer diagnostics, we have newer therapeutics, and we have new care models, which is also of great benefit for our patients who have this tough disease. So that's all I had here. And then if you want, I could do questions, or we could go on to our cases, whichever way you'll want. You want me to continue with the cases? Okay. So I have a few cases, and we can talk about them and see what would be the best plan of action for these patients. So our first patient is a 78-year-old gentleman, does not have much comorbid disease, mainly only high blood pressure, and but presented with symptoms of repetition, memory loss. Some of the daily activities that he had done for years, he was having difficulty doing now, household activities. His MOCA was 24 in 2023, and it was 22 in 2025. On his MRI scan, he showed only mild microvascular disease. He did have a neuropsych test, and it showed mild cognitive impairment. We did do beta amyloid and 40/40, and it was positive at 0.127. The beta amyloid levels drop, so anything less than 0.15 is positive. And the p-tau 217 increase, so anything above 0.15 is positive. And so he was positive for both of these. So any thoughts of as to what should be our next course of action with this gentleman? Would you or would you not consider monoclonals in him? So I'll just go. So in this gentleman, I would first start him on the donepezil, and many times, but to get the process to be able to get the monoclonals, it's a multi-step. So that's why in the interim, if they are new patients, we generally start them on the cognitive enhancers. So we did start him on donepezil, and initially he was not really interested in monoclonals, but then subsequently he was. And given the fact that he is at the mild cognitive level and he has positive biomarkers, now even though they are positive, these were plasma biomarkers. So we did have to do the CSF biomarkers, which were also positive. And usually if you're considering monoclonal, it's not necessarily in the box, in the labeling instructions, but it is highly recommended to do the ApoE testing, because individuals who have, especially if they have both the E4, they are a high risk for bleeding. And so you want to then weigh even more risk benefit. So this gentleman he would be a good candidate for the monoclonal antibody if he is interested in it. So our next lady is an 80-year-old, and she has high blood pressure. Jen,
we have a couple of questions on the chat. So,
okay.
Does the PCP make the initial assessment for dementia care, so referral for guide services can be rendered at home for the individual?
So could you repeat the question? Is it one question or
does the PCP make the initial assessment for dementia care so that referral for guide services can be rendered at home for the individual?
Okay. So as far as the guide program, there are specific places that have been approved by Medicare to be guide sites. So you would have to, so each guide program has a different process as to how they are enrolling their patients. So in some cases, means the PCP can make the diagnosis and then refer to guide, and then that guide program may have a process that they will do their evaluation before they're enrolled in guide. Does that answer that question? Because the guide, so sorry.
Oh, he replied back, he said, what do you do when the individual is displaying MCI won't leave the home? So, yes.
So MCI does not qualify for guide. So you have to have a dementia before you can qualify for guide. To see the chat out
there. There's another question from Jim Partial. It says, what about other dementia programs, such as those by the Alzheimer's Association, to assist caregivers with dementia care as outpatients, to avoid hospitalization, caregivers stress, and improve quality of life for our patients?
So the Alzheimer's Association has a lot of, means it has a lot of programs, a lot of education as well. It has caregiver as well as it has a number of caregiver support groups, but it is each Alzheimer's, there are different, every place has their own Alzheimer's Association, kind of group. And so it depends on what services are present in your locality. But it is always a good resource to actually just kind of put in the area and see what resources are available at that time, in that area. They do have caregiver support groups and caregiver trainings as well. So yes, it is a good resource. There's the PCP maintenance. So the PCP can always make a diagnosis of dementia if they're comfortable with it. And as we mentioned, for guide, you can, it depends on how the programs are set up in your area. I'm not sure as to the guide, if there's a guide program in your area, but like in our area, we have at the University of Louisville, we have a guide program. There are like 3 or 4 guide programs in Louisville. So they can be multiple, and each one has a different way of how they function. So I would suggest kind of finding out if there is a guide program, and then what is their process for referral, and then that would be what I would do. Okay, let me see. So our second lady is an 80-year-old, and she has high blood pressure, cholesterol, sleep apnea, but she is unable to tolerate her CPAP now. She's newly diagnosed with atrial fibrillation and is on Eliquis, and she's also got a history of COPD and is on oxygen therapy. Her MoCA was 22 out of 30. On her brain imaging, she's had like moderate volume loss, moderate amount of hypodensities, which was suggestive of moderate level microvascular disease. We did not do the beta amyloid and the p-tau because the patient and family didn't specifically want to know if they did or did not also have Alzheimer's disease, because given her vascular pathology, she does have vascular disease. And given the fact that she's on anticoagulants, she is not a candidate for monoclonal infusion therapy, antibody therapy. So management wise, it wasn't going to make a difference. So they did not really want any additional testing. Our next lady is a 78-year-old, and she actually presented with she initially thought a lot of her symptoms were related to anxiety, but she was having some difficulty with short-term memory and word finding. She had an MMSC done in 2023, and at that time it was normal at 28. We did a MOCA in 25, and it was 21. On her brain imaging, she only showed some mild microvascular disease. There were some small areas. It said hemosiderin, but on recheck, it was basically like microhemorrhages. They were less than 4. Her plasma biomarkers were positive. So 40/40 was 0.14, and the p-tau was 0.45. She had a neuropsych testing, and it showed amnestic MCI. So this lady would be considered to have like Alzheimer's. Her memory issues are likely related to Alzheimer's disease. She also did have CSF testing, which was positive, and did also have the ApoE genotype testing, which was E3E3, which is not the high risk. It's the most common, but it's not the high risk for bleeding. And so she isn't going to be getting like the monoclonal. We would also on her start the donepezil, memantine if need be, but really get her on the monoclonal infusion therapy. Our next lady is 78, and she had pretty similar symptoms to our previous lady, mainly more anxiety and memory. Her MOCA in 23 was 25, and then she had on MRI mild disease. Her beta amyloid plasma testing was positive. She did subsequently undergo CSF testing, and that was also positive. She has the E4 genotype, so she is high risk for ARIA changes. But she did actually go on to get the monoclonal antibody therapy with lecanemab. She unfortunately did have an episode of ARIA develop, and so the infusion was stopped and it cleared, but she has not restarted and would strongly not recommend restarting. Then our last lady is a 67-year-old. She has actually strong family history. She has been worried about potentially developing Alzheimer's disease. So she has been very proactive on this. So that's why she has multiple MOCAs. For years, her symptoms were kind of put as if it was anxiety. But so in 23, it was 21, and now it is dropped to 19. On her imaging, she has mild disease. On her biomarkers, it was positive. She had an amyloid PET, and that also showed it was positive for amyloid. She also has the E4 and genotype, so she is at a higher risk for bleeding. So her family, she kind of feels like she wants to do the medication, but her family definitely does not want her to. I would err on not doing it. She is functionally doing well. She is a higher risk for the complications.